Autosomal dominant tubulointerstitial kidney disease, ADTKD. Previously, we used to call it the MCDK, multicystic dysplastic kidney, and it's really familiar. The disease is interstitial inflammation, and the name suggests genetic disease, autosomal dominant inheritance, and the little bit insidiously progressive, slowly it progresses to CKD due to tubular interstitial inflammation, turning to fibrosis, and plus minus at times there can be cyst and bland urinalysis. Normal almost the good amount of time. In despite inflammation, urine analysis reveals almost nothing. Sediment is absent. So this is what the new entity like, and it is a genetic disease caused by the your UMOD, the uromodulin, the MUC gene, RAN gene, HNF5B, and DNA JB11, and SEC6A1 gene. So it is a different little bit of genetic disease. So commonest are the uromodulin and the MUC gene defect. These two are more common in the adult population. Adolescents and adult presentation is therefore more common, but pediatric presentation is also possible. Apart from the tubulointerstitial inflammation, these children do have uric acid elevation, hyperuricisuria, and contribute to CKD progression slowly, very slowly. And the associated disease in the RAN, your renin gene defect, they do have the anemia disproportionate to CKD progression, and so there are times good outcome. There are times that disappear in the course of time. Your HNF1B gene defect is quite important, and then these children do have an adult also bilateral renal cystic hypodysplasia. They have the vesicoureteric reflux, the MCDK, and hyperglycemia, hypomagnesemia, and hypokalemia. So they have, because they have hypoplastic pancreas and maturity onset diabetes moody. So this is important, and the your other two, the DNA JB11 variety, they are adult presentation. The SEC61A2, it can have early presentation with a small cyst. So diagnosis is by cyst identification, your the interstitial inflammation identification, tubulitis, interstitial nephritis by biopsy, and the genetics, as I said earlier, autosomal dominant and 6 genes involved. So next generation sequencing must be done, and uric acid should be checked, and differentially nephrophthisis is possible, and other cystic disease, polycystic kidney disease is possible. Treatment is supportive of CKD and your hypertension infection control, and the uric acid by allopurinol, febuxostat, and other cases, your renin defect, the ADTKD by RAN defect can be benefited by your ESA, erythrocyte is stimulating agent, and little bit steroid, fludrocortisone may be useful at times.